Good evening, folks. I'd like to welcome everyone for our clinical meeting here in São José dos Campos in Hospital Orto. I'm very happy that today we are going to discuss such interesting topic. We are going to talk about non-operative treatment in knee osteoarthritis. And I have two guests that we're going to be sharing their experience with me tonight. First of all, I'd like to thank so much Professor Damir Hudetz from Zagreb, Croatia. Thanks so much, Damir, for you to accept our invitation to be here with us so late. I know that's so late for you, but thanks so much. Professor Hudetz is the head of the department from orthopedic surgery at St.Catherine. And the other guest, it's a well-known guest, good friend of mine, Dr. Marcus Nali. He's the head of the knee department in IMOT in Mogi das Cruzes. Nali, thanks so much for you to accept my invitation. It's a great pleasure to have you here with me. We are planning this presentation to have, first of all, we are going to have 30 minutes of presentation of Dr. Hudetz, Professor Hudetz. And after this, his presentation, we are going to have more 30 minutes to discuss about some topics, to receive some questions in the chat. Okay, so Professor Hudetz, thanks again so much. You can start. Thank you.
Well, once again, thank you very much for the invitation. It's an honor to participate at the meeting, and it's really nice occasion to discuss about this topic. I hope that you can see the screen right now that I'm sharing.
Yes, yes.
So I'm going to enter the full screen mode.
Mm-hmm.
So that's basically the title of the topic that I'm going to talk about. So I'm going to focus on the therapy with mesenchymal stem cells that are derived from adipose tissue, in particularly in knee osteoarthritis. So these are my disclosures, and what I'm going to talk about is basically the standard surgical operating procedure that I'm using and the system for tissue processing. Then I'm going to talk about the analysis of the cell types that we are using within this product that we deliver into the joint. I'm going to try to focus also in terms of knee osteoarthritis classifications to basically better define the indication of where and when to use this sort of treatment. I will also address the issue of use of MRI in knee osteoarthritis, because that was a very nice study that we have done 3 years ago regarding the effects of mesenchymal stem cells that are used in treatment of knee osteoarthritis. And then this particular degeneric knee osteoarthritis study that was published. And of course, I would like to show you some clinical cases of ours that we did. So first of all, regarding the surgical operating procedure and the system for tissue processing, the whole idea of the non-surgical treatment of knee osteoarthritis is basically an idea of intra-articular therapy. So what we all basically know about these intra-articular therapies is that the accuracy of intra-articular injection is of utmost importance in all these treatments. We have had previous experience, and it's not basically the topic of this presentation, but we have had a vast experience in delivering different other medication or treatments like PRP treatment, and we know by doing so that it's a really important issue, the accuracy of injection. So We are delivering basically with all these sort of intra-articular therapies, large and small molecules that basically rapidly exit the joint. So that's the downside of all these treatments. And if we know that the most commonly used sort of treatments like steroids or hyaluronic acid, they have an extremely short half-life within the joint. So steroids have a half-life of 12 hours as opposed to hyaluronic acid that have half-life of let's say around 48 hours. So the path via small blood vessels and lymphatic system enables all these molecules to exit or to leave the joint very fast. So that's basically the mechanism that does not enable all the molecules that are very important for our treatment to stay within the joint unless we do some sort of different approach. So this is basically the procedure that we are using for harvesting the tissue, the fat tissue, and once you harvest the tissue within a closed system, then you can easily process it also within a closed system. That's the lipogems system. And let me go back to that slide. Hopefully it will play right now. So now you can see that within the closed system, you can really get the fat tissue flakes, and that you can really have the microfragmented lipoaspirate that is basically just by means of physical reaction basically discarded and divided from the rest of the cells that have been harvested from the tissue. So basically, the procedure is very well established, and it's very straightforward. It takes approximately, well, let's say 20 to 25 minutes to harvest the tissue, and then to obtain 5 to 10 milliliters of final product that you can deliver into the joint. So if you compare it to the other treatments where you have just molecules, you have basically transplanted tissue, and this is microfragmented tissue that we are basically delivering as a product within a knee joint, as opposed to small molecules that can basically very fast leave the joint. So the question is, what sort of cells does this product contain? That's something that I'll try to answer later. So once when we deliver this product, we are also using a very well standardized procedure of rehabilitation that's basically delivered also through a web-based platform for all the patients, depending on different types and of osteoarthritis and indications that they have used. So there is a nice, neat product that we use for that. We have also had some complications, and within our pool of patients, we had at the very beginning a very massive bleeding at the harvesting site. So proton time was very low after unregulated warfarin intake in that particular patient. So it's also something that has to be taken into account when you treat this sort of patients. So the patients can really have a massive hematoma if they don't, if they are not addressed properly. So there are also challenges if you want to treat a very active and sportive population of patients, then it's not always very easy to obtain fat tissue from people who have a really thin layer of fat tissue, and we really always try to gain at least 5 cc's of final product of microfragmented lipoaspirate. So back to the question of what cells are we using within this product. We have had several studies that were ongoing in our St. Catherine's Hospital in Croatia. We initiated those studies in November 2015, and these are the data up to 2017. And during these 3 years, we have treated more than 220 patients with knee osteoarthritis, and we have performed 3 parallel studies. And back to the question, what cells are we using? We did the immunophenotypes of the cells, and as you can see here in the final product that we deliver within the joint, the cells are basically around 95% viable at the time when they are delivered to the joint. And there is a vast percentage of CD45 minus cells within this group of cells that we are delivering. So if we take a look at the phenotypes, then there are 3 basically groups of cells according to all the immunophenotyping that we have done. There are endothelial progenitors, pericytes, and adipose-derived stem cells, so-called supraadventitional adipose stem cells, according to biomarkers that were seen on all these cells. So these are really 3 groups of cells that are most abundant within this final lipoaspirate that we deliver. And you can also see the flow cytometry results with the non-endothelial cells and pericytes. And here you can see also stromal vascular fraction and all the immunophenotypes of the cells. Basically, they are mostly nucleated CD45 minus cells, and the 3 groups: endothelial progenitor cells, pericytes, and then adipose-derived stem cells, so-called supraadventitional stem cells, are most abundant. So these are really 3 group of cells that contribute to the effects of our treatment. And as we all know, the pericytes and the stem cells have different functions. To name just a few, they have trophic effects, they have immunomodulatory effects, and they have also antimicrobial effects. The trophic effects are basically those effects that we want and that we expect within the knee joint if we want to see some sort of regeneration or some sort of effect at the tissue that is basically damaged. And there are also last time many studies that report on endothelial progenitor cells that are and their importance in terms of regeneration in ACL and then in muscle derived and medial collateral ligament, and then as well endothelial progenitor cells are really stimulating angiogenesis. So these cells have really different trophic effects. So once when we know what from our studies what sort of cells are we using, we wanted to establish really the good indication or the patient with proper indication for that treatment. So at the very beginning, we were kind of wondering what sort of treatment and what sort of patient is basically the most suitable patient for this sort of treatment. And when we were doing our studies, we were comparing also different groups who were basically saying that they are treating osteoarthritis, but everything was basically correlated with radiological assessment in terms of Kellgren-Lawrence grade 1 to 4 osteoarthritis. And as you can see here, so that was the time when we started our studies and the papers that were available at that time in 2015 in terms of intra-articular therapy with different stem cells. The patients were divided in some studies in early or late grade of knee osteoarthritis, or those patients with knee osteoarthritis that are scheduled for total knee replacement. But in fact, there are really many different knee osteoarthritis phenotypes. And we all know that the process of degeneration involves not just hyaline cartilage, but synovial lining, menisci, bone, ligaments, tendons, and muscles, all the tissues that are around the joint. So all the old radiological classification based on just 2 plain X-rays is not sufficient for our purpose. So there is a very good paper from the group from Scotland, from Glasgow, from Delisola, and they divided. They had a insight in a really big number of patients with the knee osteoarthritis. So they had insight in all different phenotypes, and they were able to classify these phenotypes in 6 groups, and the 7th group is a complex group that combines these different phenotypes, where you have minimal joint disease, malaligned biomechanical case of osteoarthritis, or patients with chronic pain, those patients with inflammatory, basically osteoarthritic phenotype, metabolic syndrome, or bone and cartilage metabolism. And we have tried to work out our scheme and our approach according to these phenotypes. And the studies, or basically the study regarding all these phenotypes, is still ongoing. It's a very demanding study because in order to be able to classify these patients, you really almost need an artificial intelligence to do so, but it's I think, in my opinion, a very good approach, because we have seen that patients with minimal joint disease and those patients basically with malaligned biomechanical type of osteoarthritis who have combined some sort of biomechanical treatment in terms of, let's say, osteotomy, and then combined intra-articular therapy with microfragmented fat tissue, are excellent responders to this sort of treatment, as opposed to those patients with chronic pain and inflammatory who are not responding. These results are preliminary, but like I told you, we are conducting a big study defined on these different knee osteoarthritis phenotypes. But in order to be able to do so, it's also a complex question. You need to involve MRI classification, different biomarkers, scores in terms of pain, and then psychological assessment of the patient. So it's a really complex issue, but it is, I think, the best way to approach the issue. So what did we find out with the use of MRI in knee osteoarthritis? Basically, it's not a routine clinical assessment, as we all know. For classification of osteoarthritic patient, it's not even routine for follow-up, but it's particularly useful in early stage osteoarthritis because we can see intra-articular issues, and all the studies are with MRI are strongly associated in terms of pain and bone marrow lesions. So as you can see on this MRI here, you can see bone marrow lesions, and these patients basically localize their pain where you have bone marrow lesions. So what are advances in MRI imaging? So we are basically now able to see changes in chondral pathology earlier, and it's a predominantly still research tool, but nevertheless compositional MRI with degenerate and T2 mapping is able to show the composition of cartilage, where we can assess proteoglycans, glycosaminoglycans with degenerate, and with T2 mapping approach, we can assess the quantity of collagen type 2 in the cartilage and the content of it. So degenerate MRI is basically a tool that helps to assess, like I said, proteoglycan content, and with less glycosaminoglycans or proteoglycans in cartilage, there is more contrast penetration, and the degenerate index is lower. So you're able basically for regions of interest to get a very nice quantitative data for each region. So you're able to dynamically follow up the patients in particular time points, and at particular regions to really see the content of glycosaminoglycans. And this tool is available at our hospital, so we decided to use it in order to evaluate and to assess the effect of our treatment. And we conducted a study. The results were published in 2017 in the Genes, and we have had at that time 17 patients that entered the study, and it's a rather demanding issue to have patients because they have to go to receive contrast and dynamically to be assessed at the time point 0, 3, 6, and 12 months after the treatment. So we have followed 32 knees basically with Kellgren-Lawrence grade 3 and 4 scores. And as you can see, it becomes even more complex because you can really follow different regions of interest. We decided to follow 7 regions: medial, femoral, condyle, lateral, trochlea, and so on. And you can address and see with regards to mechanical alignment where the wear of how the pattern of wear in the knee looks like. So then you are able to get for each knee such a scheme or such a table with many quantitative data. And our hypothesis was that there are some changes that are detectable in terms of composition of the articular cartilage after the administration of autologous and microfragmented fat tissue in patients with knee osteoarthritis, but those were patients with grade 3 and 4 osteoarthritis. These are some patients out of that study. So you see a male patient with obvious knee osteoarthritis, and it's a medial pattern of wear. And you see the values at the beginning of the study, 3, 6, and 12 months at the left lateral femoral condyle. So this was a varus knee, and on the lateral condyle, even though it was an osteoarthritic knee, we had a good effect in terms of raise of the value of proteoglycans within that knee on the lateral femoral condyle and on different other sites. But within our study, we have never, so these are the results, what I wanted to comment. For instance, on medial femoral condyle, that was the pattern of varus knee. We were unable to assess proteoglycan content because the cartilage was completely worn on the medial condyle due to the pattern of wear. and overload in the medial compartment. And throughout the time, we didn't observe any changes in that. So we were not able to see the new, so to speak, cartilage growth at that time within this study. So another case, this is basically good alignment and more pangonarthrotic patient with all three compartments that were involved, but still it's a symmetric knee osteoarthritis phenotype involving all three compartments and even the patellofemoral joint. This patient was complaining on basically very constant effusions and function of the knee that was very restricted with pain and these effusions. And again, he entered the study, and we were able to see improvement in terms of values in those areas where some cartilage layer was still intact. So the protoglycan's content was much higher as opposed to the time 0.00 or time before the treatment. Again, you can see these values in the table here. And we evaluated all the results of this study, and out of 331 measurements at regions of interest, we have had 53% of improvement of the results, meaning that or protoglycan content was really relevantly higher than before the treatment. So this is just one aspect of the effect of the treatment, but this is obviously a sort of a really morphologically related effect of the treatment. Apart from that, we also have followed our patients within different studies in terms of function and pain and the results in those regards, and in terms of clinical outcome scores were significantly better to this compared to this, but this is also a very nice result in terms of morphological effect of this sort of treatment. So these results indicated that the use of microfragmented fat tissue in patients with knee osteoarthritis increased glycosaminoglycan content in hyaline cartilage, even though this group of patients were Kellgren-Lawrence 3 and 4 grade. So our study has shown that intra-articular application of microfragmented fat tissue with knee osteoarthritis was not associated also with any adverse events, including chondrotoxicity, which is always a very important issue, because we have seen that chondrocytes started to produce protoglycans. It's an obvious mechanism that has evolved after the application of this sort of therapy. So there are some studies that have proven that mesenchymal stem cells can contribute to regeneration of cartilage defects through homing and engraftment and production of cartilage extracellular matrix. But in our study, we were not able to observe so, but we were basically addressing just protoglycan content, and these are related, and the content of protoglycan is related to activity of chondrocytes. And we were not able to show that in those areas where the destruction has already been complete in terms of bare bone and exposed bare bone, that we were not able to observe any new cartilage formation. But positive effects of this therapy most likely were via trophic and immunomodulatory mechanisms that induced the host chondrocytes to proliferate and to produce extracellular matrix in terms of protoglycans. So all these data suggest that increased proteoglycan production directly influences also hyaline cartilage quality, and this was very well related with improvement in terms of clinical outcome measures. So how about cartilage defects? Those would be not the patients with knee osteoarthritic with knees in terms of osteoarthritis Kellgren 3 or 4 or very late osteoarthritis. That's more related to cartilage microtrauma. So how about that? So if you compare these two cartilage cylinders, they macroscopically look very or pretty much the same. You cannot see any sort of difference. But if you use the scanning electron microscope, even if you have a smaller magnification as on these two images, you can see the left cylinder. So those are the two cylinders, and the left cylinder has a cartilage defect on in the superficial layer. So if you even dive deeper into the structure, then you see collagen fibers in scanning electron microscope. So these are the sort of defects that where you can really expect some sort of regenerative effect of this sort of treatment. And this is a patient with good alignment. It's an older patient, but still the cartilage was intact, and we were not able to see osteoarthritis in terms of a late grade. So this sort of patients really respond very good to this sort of treatment, and we have had several top athletes that use this sort of treatments, one of which is shown here. He used to be a very famous athlete in Croatia, and at the time when we were performing our studies, he had really big trouble with his knee because he wanted to stop his career. And you can see also chondral defects, especially on the medial femoral condyle here. And he was having a lot of effusions, and he was not willing to undergo a sort of cartilage procedure that involved basically 6 weeks of non-weight bearing and then a long recovery in terms of 8 to 10 months to start even to train, because he was at the end of his career. So he had also an excellent response to this sort of treatment, where we were able to kind of postpone his retirement at the top level for 3 years by doing 2 times this sort of treatment. So to conclude, we have experience with very good results in treating patients with cartilage defects without severe excess deviation in the phase of cartilage delamination, where you still have some cells and at the lower layer of the cartilage, and where the chondrocytes are able to respond to this sort of treatment, to this sort of biological treatment. And this sort of therapy really improves function of the knee really fast, especially if you have cartilage delamination in terms of swelling, because the collagen fibers that were seen on those scanning electron microscope images are basically not able to be released once the structure is being stabilized with this biological treatment, and they are not basically irritating the synovial lining within the joint, and they are not producing, and the synovial lining is not producing excessive synovial fluid anymore. So that reduces also pain and helps in terms of range of motion improvement. But in severe axis malalignment, we have had very good results with patients who have been treated accordingly with osteotomy. So combination of this sort of treatments gives also very good results, and that's also related to the knee osteoarthritis classification, phenotype classification that I was talking about. So with that, I would like to conclude my presentation, and I would be glad to have discussion with you on that topic. Thank you for being patient and listening.
Damir, thank you so much. Such nice presentation, really interesting. And I'd like to open for my colleagues, Marcos, Nali, and even Marcelo. If you have some questions to Damir, please feel comfortable to ask him.
Yes, good evening, Dr. Damir. Good evening, Marcelo. Good evening, Cristiano, for inviting me. Dr. Damir, in your experience, what is the ideal patient for the interarticular injection microfragment fat?
Well, the ideal patient, I don't know if you still see the presentation, but the ideal patient would be mild osteoarthritis. So really where you have some sort of still cartilage layer intact, at least. So if it's not a complete bone-to-bone patient, then that would be the best indication. And if you can exclude really some other metabolic issues, and if you can exclude chronic type of osteoarthritis, chronic pain type of osteoarthritis, then that would be an ideal case. So really delaminated cartilage, maybe with a fusion and good bone alignment, and then that's potentially a very good candidate for this sort of treatment. And if he has an additional malalignment, then you can perform a sort of you can address mechanical issue in terms of osteotomy, like I presented within my presentation.
Mm-hmm. Damir, just following the same idea as Marcos Nali asked you. So the patient with that doesn't want to go for a total knee. Mm-hmm. Cases that patients they want to wait. I did all the treatments that I have available, and now I'm using the lipogen. So in your opinion and in your experience, these are not the best indications. What do you think?
These are not the best indications because patients would like to have basically a result that lasts for a longer period of time. And from our experience, we have also published the data within a study. We have had patients, 21 patients also within a small study, a prospective study that was done. And all these patients were basically scheduled for total knee replacement. And they have had severe pain. They have had restrictions in terms of range of motion and then function, and they were involved in the study. And within 1 year of the study, basically 75% of the patients were able to function without being operated, in terms of good improvement of range or level of pain. And they didn't want to go after 1 year, or within this period of 1 year, they didn't want to undergo the replacement, the total knee replacement that they were scheduled for. So let's say that's in grade 4 osteoarthritis the case. you can expect to have around 75% of the patients that have a certain level of improvement, but not for longer time than 1 year, based on our results.
And Damir, another question. Do you have experience treating the same patient twice or 3 times using the same methods?
Yes, we do have. We have had more than several top athletes, one of which was shown within this presentation. And if a patient has also a top level of activity, and if it's if a patient is all the time loading his knees and bearing excessive loads and weights within training process and then competition, then you can repeat, and they usually also have some sort of response to the therapy for, let's say, 1 to 2 years at the top level. And then you can repeat the treatment. We have had the same also respond with the osteoarthritic patients, and we repeated also between 1 and 2 years in osteoarthritic patients the same therapy, and it was functioning again for the same sort of period of time.
Very good.
Like another questions. What is the main function of the microfragmented fat in the knee? Anti-inflammatory or regenerative?
Well, what we have explored and what we have proven in our studies, it was not anti-inflammatory effect. It was some sort of trophic effect, and it was basically an effect that was due to the function of chondrocytes, and that's our Degemerich study that has shown that. But we know that the 3 cell types that are most abundant within this product that you deliver into the joint, that they have really a very strong anti-inflammatory activity as well. So that's obviously one of the mechanisms. That's just something that we were not exploring ourselves. But we know when you find these sort of cells like parasites, then you know that they have, and if they are abundant in a sort of mixture of cells or in a tissue transplant, like this sort of therapy basically is. This is just a transplantation of the tissue. Then parasites are able to control the inflammation, and then you can expect also to have a very good response with those regards in terms of much less inflammation within the joint.
Dr. Damir, we have some questions from the audience. And the question was back a little bit to science, you know. You shown clearly 3 types of cells, and what cell is more important of the 3 types, the 3 main types that you show?
Well, it's basically the positive side of the treatment, that you are delivering different cell types, and these cells have different pathways of functioning. So you cannot say that one of these cells has greater importance as opposed to the others. What we know, that parasites are basically those cells that have really very important functions, and parasites were promoted as cells with potentially most important functions in terms of regeneration of tissue and in terms of controlling of all the processes with regard to inflammation. So parasites would be the cells that are most important from the perspective of the results that have been published, or in terms of what has been explored and documented within numerous studies, especially studies from Professor Kaplan. So he has investigated parasites as medicinal signaling cells, so these cells are able to deliver really different products in terms of signaling proteins to the rest of the cells, and that's basically the mechanism as we think now that this product works, by signaling other cells. So parasites would be those cells that we know really a lot about right now, and then those would be the cells that would be, from that perspective, the most important. But that does not mean that the rest two type of cells are not also important.
Okay, so another question. Do you have an idea, or if it's possible to quantify this kind of cells? For example, 10% is MSCs, 20% endothelial cells, or other type of cells. How is the percentage of cells? We know that it's depend of the patients, of the genetics and the other things, and metabolic of the patient. But in general, it's possible to quantify the quantity of the cells?
Well, it is very easy to quantify the percentage of the cells. What we kind of expected at the very beginning, that we have that the parasites would be most abundant cells, but then the endothelial progenitor cells have shown to be the most abundant type of cells, but it depends. It really depends on the type of the patient. It is also gender dependent. That what we have published also in another study, basically you are able to do immunophenotyping of the cells in each sample if you would like to. So you can really quantify and see what's the ratio of the cells in each sample if you want. So it's also really demanding. It's just for the purpose of the studies. But it's easy to see the ratio of the cells in that regard.
Okay, one more question, one fresh question now. How many cells do you think is the best to inject? Any best concentration or number of cells, or this is not relevant for this kind of injections?
Well, what we know from as an orthopedic surgeon, I can tell you what's basically the best volume of the final product that we want to deliver within the joint. It's between 5 to 10 cc's, and basically, if you compare the number of the so to speak, stem cells, and that would be parasites and adipose-derived stem cells, to the number of bone marrow derived stem cells, then in fat tissue you have much higher abundance of stem cells as opposed to bone marrow derived stem cells. And clearly, we cannot say the exact number of the cells that we deliver, because obviously it's not standardized yet. It's just standardized in terms of volume of the tissue that we are transplanting. And we have published a study on immunophenotyping of all these cells. And we are basically investigating in that direction further, our group, and we will most probably come up with some recommendation of the cells and standardizing of the treatment in future, but we still did not publish the results yet.
Okay. I have a question.
So,
what's your experience in microfragmented fat associated with the surgeries? It's only osteotomy or arthroscopy too?
Well, we are basically in knee. We are using it in combination with osteotomies. So that's the most common indication. In shoulder surgery, we are using it for rotator cuff repair as well. And in hip arthroscopy, we are doing it additionally with labral repair. But we are not using it yet for meniscus surgery, though I think it could be a potentially very good indication. And there are some studies that have been published in terms of meniscal repair and use of this microfragmented lipoaspirate treatment. So I think it's also a potentially very good indication. So that's basically our experience, to use it in combination with osteotomy, or to use it in meniscectomies just as adjacent procedure. But then my personal experience is better to use it 6 weeks after arthroscopy.
Thank you.
Damir,
yeah.
The indication here in Brazil, we are starting with this procedure, and when we start to talk about this, it's always a question about indications.
Sure.
After your presentation, can I say that as early as I start treating cartilage damage, I will have better results?
Well, of course, but the question is if the patient has really, basically, if he presents or if the patient presents with some sort of symptoms, then you should start treating as soon as possible. But of course, if you have an asymptomatic patient with, I don't know, with an MRI scan, you wouldn't start treating him with this sort of treatment, even though it would be most probably a very good indication, because as we have seen, you will have a very good response from the chondrocytes, and they might start. They will start produce extracellular matrix, which is very important for the cartilage function. So the sooner the better, of course, but you have to correlate that with the basically clinical presentation of the patient.
Mm-hmm. Do you follow steps to reach this kind of indication? For example, physiotherapy first, then hyaluronic acid injection, and then you go further for the lipogenes? or you don't follow steps?
Yes, we have had also patients who have had previously hyaluronic acid treatment. I have also in another presentation some patients of that kind who have had, for instance, treatment with hyaluronic, first with physical therapy and then hyaluronic acid, and they responded like you usually do. You treat patients with hyaluronic acid, and then if they are good responders, then you would expect 6 to 12 months of clinical improvement after you give hyaluronic acid. So these patients had repeated hyaluronic acid and have been repeatedly responding good to hyaluronic acid, and then they had some sort of PRP treatment. They responded, I know really few cases like that. They responded good to PRP treatment, and then they stopped responding. The last therapy with PRP treatment did not bring the improvement in terms of clinical scores, and then they received microfragmented lipoaspirate, and then they again felt improvement. So that would be also on probably the answer to your question. You can do easier approaches at the beginning, and then this is really the therapy that has stronger biological effects if you compare it with, of course, hyaluronic acid and PRP treatment.
I have a question. You use microfragment fat articular degeneration femorotibial, and do you indicate it to patellar degeneration too?
You think to patellar tendon degeneration?
No, patellar cartilage.
Femoropatellar joint.
Femoropatellar joint.
Yes. Yeah.
Yes, we have patients, but it's a complex question. Of course, if you have some sort of patellar instability, then it's or mechanical issue at the patellofemoral joint, then it obviously does not help. If you have some sort of cartilage fraying or cartilage damage without any underlying trochlear dysplasia or instability of the patella, then you can expect good result with this sort of therapy. If it's just the cartilage delamination, if you have instability, or if you have I don't know, malrotation of the femur, of the distal femur, with excessive overload on the lateral side of the patellofemoral joint, then you cannot expect miracle from this sort of therapy. Then you would have to address that issue before you start microfragmented lipoaspirate treatment. But if you combine these two, then again, it's these are those patients where you can combine this treatment, also some sort of biomechanical surgical procedure, and then biological treatment like microfragmented fat tissue transplantation adjacent to biomechanical treatment.
Damir, just I'm going to make the last question for you. We are on time right now. Tell me about your protocol. You are doing more just injections, or you're doing arthroscopy, treating all the problems in the knee, the mechanical problems, and then you add the biological treatment in the end?
Well, I'm primarily a knee surgeon, so I mean, I'm an orthopedic surgeon, and I do primarily surgical procedures, and then this is an additional tool that really helps me because sometimes you're not able to do by means of surgical procedure what you can do with this sort of biological treatment. So I think really it's an excellent tool that you can combine with different procedures in terms of surgery. So I'm trying to combine these two. And if I see that a patient has not underlying any biomechanical problem, then I would just treat him with this sort of therapy without any surgical procedure. Mm-hmm. So that would be the easiest scenario, but you have to really to analyze the patient. So that the answer would not be straightforward. Okay, well, you should use this without thinking. That was also my message. And that's where our study is now going to really define these different knee osteoarthritis phenotypes and to think about it. And if you have really a well-aligned knee, for instance, if we talk about knee today, well-aligned knee without any biomechanical issue with a worn cartilage, then you would just need to do this sort of treatment and you can really expect very good results in terms of improvement of function of the knee, in terms of improvement in terms of pain related to swelling and inflammation within the joint. So that would be then the easiest basically scenario to use this sort of therapy. But even in more complex scenarios where you have some sort of additional pathology that you can treat, you can very nicely combine this sort of biological treatment.
Perfect, perfect. Marcelo, Nali, can we end the questions? Do you have any other questions? It's our time, it's 5 minutes already.
No.
Marcelo?
No, thank you, Dr. Damir. Thank you, Dr. Cristiano. Congratulations for this understanding presentation, Dr. Cristiano.
Damir, thank you so much. Marcelo, Marcos, Damir, again, it was an excellent presentation, really clear, fantastic. I'd like to thank you so much to accept our invitation, and I wish you to have more opportunities for us to be exchanging this kind of experience. Thanks so much.
I would be glad to participate in the exchange of experiences, and I hope you will be able to show me also your experiences very soon. And I'm really glad that you invited me to participate. It was really an honor and pleasure. You were very nice. And it was, in spite of being so late, now I'm awake, so I could stay a little bit more.
Thank you so much. So guys, for tonight, we end our meeting. Thanks everybody, and please follow up us in a web from the hospital. Next month, we are going to have another meeting, and we are open to exchange our knowledge. Good night. Bye-bye.
Thank you.
Bye-bye.
Good night.